Okay, good evening, everybody. Nice to see everybody signing in again. It's good to see you all. I see some new faces, but also some old faces who we haven't seen in a while. So it's good to have you back. Hi there, Yetta and Sherry. And those of you who can turn on your video cameras, that would be amazing, so that we can see you and this can become a little bit more personal. For those of you who can't turn on your videos, we understand. But for those who can, it's nice to be a nice cohesive group. We've kind of become somewhat of a team and a family over these past 2 years of Mondays with Moshe. It's Monday night, 9:02, June 27th, 2022, and we're ready for another episode. I want to thank Chana Mark for joining us and preparing this discussion. Tonight's discussion is the curative process of psychotherapy. What heals? This is a sort of mystery that many people have been trying to pay attention to and gather data, and has never really gotten a clear answer. You know, there are some who believe that some of the cognitive work, people working on themselves cognitively, there's some people who still, will go to Musser and say, we got to learn self-improvement, and that's really what changes us. There are others who might argue that there's something about the somatic experience that changes and heals a person. And there are others who argue that it's really understanding your past and identifying with your past and developing self-compassion that heals. And some say the relationship heals, which just seems to be a very mystical idea. What does it mean the relationship heals? And again, there's different levels of understanding as to what it means that the relationship heals. So with that in mind, I'd like to introduce Chana Mark, who is a licensed clinical social worker out in Muncie area, New York, Rockland County, somewhere around there. And Chana has been on this show before, so this is, I believe, second or maybe even third time presenting. Yeah. And Chana thinks that she has the answer to this question. Okay, and I also think she does. But we're gonna learn something tonight. Chana is always very profound and wise information to share. So I'm really hoping that we're going to get some insight tonight as to what's really going on in the therapeutic process, what really makes the healing in the therapeutic process. And of course, I invite you to challenge or question anything that you don't understand or are not sure about. We'll be happy to take your questions. I'm going to remind you that the way to do so is to raise your hand by using the reactions tab on the bottom of the screen, bottom right of the screen where it says reactions. Click on it and click raise hand, and we'll be sure to take your question. I need some leaders here who would be willing to ask the first question, because what I find happens is that once we get one question, suddenly there's a myriad of people raising their hands, and unfortunately sometimes that happens too late and not everybody gets their question in. So for those of you who have a question, please jump in, raise your hand, and we'll be happy to address it. Chana, just give us 2 minutes of who you are, what's your background, how did you get into this field, what did you specialize in, or before reaching where you are today?
Oh, all right. Thank you. Actually, this is a second career for me. When I first started working, I was a software developer, and I enjoyed that very much. I like the technical. I have very strong mathematical background, but it wasn't enough. It's fun. It's enjoyable. I was good at it. But I always wanted to do something more, something else. And due to factors of my background, I think this is something we all share. I was forced into a position to have to be very perceptive about the people around me. Many of us begin that way. I decided to go back to school and get the quickest track at that point in my life. Was in my late 30s, early 40s, was to get become a licensed clinical social worker. And that's what I did. I went to NYU University, and I subsequently trained for 10 years with a psychoanalyst of international renown. His name is Rogelio Sosnick. He's originally from Buenos Aires, Argentina. And from him as my basis, I really learned a great deal. And he also made sure that I kept reading and studying, which was something that not only nourishes me constantly, but it's something I'm constantly encouraging others to do, to continue to read and to continue to study. I am a psychoanalyst, psychoanalytic psychotherapy. That is where I find myself working. Okay.
Chana, can you just would you be able to tell us what is the difference between a psychoanalyst and a psychotherapist? Is psychoanalysis a kind of psychotherapy? Is that what it means?
Well, let's take a look. I think that the both of them have in common the word psyche, and I think everyone would agree that the psyche is the unconscious mind. So I think psychotherapy has sort of just been someone who works with emotions and experiences. It's become a rather broad term. Psychoanalysis, very specifically, focuses on the unconscious mind. It's what Theodore Reich called listening with the third ear. As someone is speaking, we're trained to follow their associations and the underlying meaning of what those associations might be. And our interventions are they're crafted in a way to sound like conversation, but actually we're speaking, as Freud said, and as Hindi once famously said in one of her presentations, Hindi client said, it's the unconscious mind talking to the unconscious mind. I mean, it's our unconscious mind that's sensing the person's unconscious mind. We're now formulating words for that in a way that the patient will be able to grasp and understand. And that's, I think, in a nutshell, what the process looks like. Okay. Are there any other questions you have for me, Moshe?
Yeah, let's so tell us a little bit about the curative process. What's actually going on in psychotherapy and what's healing?
Okay, so now that really is the springboard for my presentation. And before I start, you had started with questions. Just speaking to everyone, this is a very structured presentation, and there are going to be natural stopping points. The way I would like to proceed is I'm going to lecture, and then at those natural stopping points, I'm going to stop and take questions. I think you'll reap the most benefit. When I formulated this presentation, I had I had where people will ask questions or have questions in mind as I develop this presentation. Okay. Now, for my introduction here, I'd like to tell you that I was listening to Mondays with Moshe, and those of you that have watched Moshe in action have probably observed that he is a very skilled interviewer. And the person he was interviewing happened to mention something about this therapeutic connection. And Moshe said, can you tell me what are the curative factors of the therapeutic connection? Is that a bomb question or what? I was absolutely taken away. Now, the person he was interviewing wasn't prepared for the question. He gave some kind of answer or response. But really, I think one could write a book on it. So that's why I've entitled this Some Thoughts on the Curative Factors of the Therapeutic Connection. I'm going to share some thoughts with you, which I hope will stimulate other thoughts in you. Also, at the end of this presentation is probably going to be in two parts. I'm going to do the first half now, and Moshe and I will schedule, I think, another session because there's a great deal of material here. In any event, after this presentation, I've given Moshe a reading list, and I'm going to ask him to please distribute it to everyone who's come, and please read. Doesn't matter where you start. Something here, something in what I've said will trigger in you your own thoughts, your own process, your own formulations. There's a reading list of many articles, books. Please pick one and start reading. It's very, very important, and you'll be enriched by it. Okay. I'm going to start. Before we proceed, we must take note of the fact that many of our patients are unable to connect to others in a reality-based or productive way. They struggle in their most important relationships, and they struggle with us also. In addition, they are unable to connect with themselves. When they dare get a glimpse of what's going on the inside, they might find that experience very threatening. They may even experience fragmentation and chaos. When this is the case, our task is to enable them to move from this fragile and agonizing position to a position of productive engagement with us. As our work proceeds, they can then take the template of healthy relating, which they develop with us, and bring it to the important relationships in their own lives. In order to understand what constitutes a successful therapeutic connection, we will look briefly at how human connection evolves and develops from the inborn neurological potential to relate to others and culminates in satisfactory interpersonal development. Satisfactory interpersonal development consists of two parts. The first is the capacity to relate in a reality-based way, at least most of the time, with the people around us. The second capacity is, in Donald Winnicott's words, the capacity to be alone. This means the capacity to be comfortable with oneself and one's thoughts and feelings. The capacity to be alone is the capacity, what? To relate to ourselves. Ideally, these two capacities together will extend to being comfortable will extend to a person being comfortable formulating his own thoughts and subsequently sharing what he's formulated with other people. To deepen our understanding, we'll turn to the work of John Bowlby, Melanie Klein, Donald Winnicott, and Margaret Muller. Each of these great thinkers contributed to our foundational thinking about the development of satisfactory human connection. John Bowlby lived from 1907 to 1990, and he's the father of modern attachment theory. I think all of you are familiar with it. He contributed the knowledge that every infant has an inborn need to have a continuous and unbroken attachment to his mother throughout infancy. If this is achieved, it creates the foundation for what he called secure attachment. Secure attachment to his mother then extends to his, just naturally assuming that he can have a secure attachment with other people. He has that template inside. For the purposes of clarity, we will define infancy in this presentation as being from birth to age 3. Melanie Klein was born in 1882 and passed away older than John Bowlby, and in fact, Bowlby studied with her. She was a pioneer in exploring and making known to us the unconscious mind of babies and young children. Yes, babies and young children. And her work was an extension of the work of Sigmund Freud. Her researchers showed her and us just how crucial the maternal bond is for the successful intrapsychic development of infants and young children. The internal development. Very, very important. The maternal bond is crucial for this. Donald Winnicott lived from 1896 and 1971, also studied with Melanie Klein. He started off, though, as a pediatrician. This gave him the opportunity to observe mothers and infants together. His insights about mother-infant bond and what we now call the holding environment offer us tremendous knowledge about the nature of successful therapeutic connection. We're going to elaborate this as we go. Margaret Mahler was born in 1897, lived to 1985, and she spent decades studying the interactions between babies and their mothers. She discovered that there are specific developmental stages of interpersonal development that proceed from birth throughout babyhood, universal to all babies. As a result of the work of these great thinkers and of others, we take for granted today that if there were disruptions of attachment early in early infancy in the form of abuse or neglect, that childhood and adult functioning will be severely impaired. Now, let's ask, what exactly is successful human functioning? We defined before what successful connection is about. What's successful human functioning, that overall, what makes a person successful in life? Freud distilled it beautifully as the ability to love and work. Love refers to being able to have meaningful and satisfying relationships. Work refers to being able to engage productively with the world in a reality-based way. Doesn't that say it all? In order to understand how to bring our patients to this place, we will explore the work of those thinkers that we've mentioned above, and we'll use Mahler's discoveries as our starting framework. She discovered that there are three main phases in development from birth to age 3. We're going to start looking at those phases now. The first is called, okay, are there any questions before I start the actual technical presentation? Are there any questions about what I've said so far? Okay, I'm going to proceed. The first of Margaret Mahler's phases is called the normal autistic.
I'm sorry, Chana, I do have a question.
Yes.
When you talked about relating to people in reality-based way,
Right.
How are you defining reality-based?
It means that I relate to you in a reality-based way if my emotional responses to what you've said are attuned to what you actually meant. Now, I'm assuming that we're assuming that you were clear in your verbiage, that there wasn't room for cognitive misunderstanding. Okay.
Mm-hmm.
If you say to me, for example, Han, I really would love to talk to you, but I can't talk to you right now because I'm busy with something. And I got into an existential rage about that because you were dropping me and you were rejecting me. And here I was, and you didn't want to hear me. That's not reality-based. Okay. Okay. Now, so let's start understanding how healthy connection, reality-based connection, has a chance to develop. The first of Margaret Mahler's phases is the normal autistic phase from birth to 1 month. Now, anyone who's ever spent a lot of time with newborns cannot help noticing that a newborn seems to be responding exclusively to bodily sensations and from basic internal and instinctual drives. He does not seem to be aware of his connectedness to his mother. He cries when he's hungry and uncomfortable. Often his eyes are closed as he's attending to internal stimuli. He eats, he sleeps, he excretes. That's what newborns do. Mahler called this phase normal autistic because, like autistic children, the newborn does not seem to be relating to others in an I-you sort of way, not at the very beginning. Melanie Klein discovered that at this early stage, the infants, in fact, continue where he left off in the womb, so to speak. Internally, he's still merged with mother. He does not yet have a lived concept of the distinction between you and I. Hence, the notion of a boundary that separates you and me is not yet possible for him. For patients who are merged with us, or who seem to regard us as an extension of their own mind, or regard our mind as an extension of their mind, over time, they'll become introduced to the new idea that we're separate. We have a separate minds and we have separate insides. By mind, by the way, I mean the sum total of psychologically relevant internality. I think everybody knows what I mean by mind, but I want to make sure that's clear. I don't just mean logical, or I don't just mean, logical or cognitive activity.
So what does a merged client look like? What's his
Ah,
class?
Okay, here it is. Patients who are merged with us, look at that, Moshe, right there. Patients who are merged with us automatically respond to us as if we feel what they feel. And when the patient begins to discover that you and I are separate with separate minds, this may evoke in the patient anxiety or rage, because as the patient becomes aware that we are separate, it may cause him to experience that we are like rupturing him, cutting him loose, and that we are being abandoning, we're being rejecting, we're being narcissistic, we're only thinking of ourselves. And we do see this in borderlines a lot. As soon as they start feeling the separation and the difference, that sometimes our needs, like when we take a vacation, or when we whatever it is we do for ourselves, this very often evokes rage or feeling wounded, and this is because these patients have never really learned that they can safely separate. And when we encounter this, we can be attuned to this and always address it ever so gently, very, very gentle. Around the end of the first month of life and beyond, the infant does become aware of mother as separate, completely connected to him and him to her, for sure, but not one with her. Listen, they are connected. When he calls, she comes. When he calls, she comes. Okay, they're connected. Okay, Mahler called this dual unity. We know, as Mahler knew, that the countless times that mother responds to the infant's needs is something that gradually gets registered in the infant's nervous system and psyche. Over time, he learns that mother is there. She is a being who responds to him when he needs her. By the time a baby is a month old, some of the anxiety about survival lessens, and he can come to rely on the fact that when he needs, mother will come. And over the coming months, this relying on mother will be reinforced and consolidated. It is clearly the foundation for secure attachment. Moshe, did you have a question? Or did anyone? Okay. There are several components to what we call secure attachment. The first was already mentioned, that I can depend on mother to provide me with my needs. The most well-known component of secure attachment is what Erickson called basic trust. Basic trust means I have learned to trust, and that the people around me, the benevolent beings, are trustable. Hopefully, he will go on to develop the capacity to be able to depend on mother, to rely on people that can help him. Next, we have the very fact of being held. By this, we mean more than just physical holding. Donald Winnicott discovered that holding extends to providing a reliable, nurturing environment, both physical and emotional, in which the infant can develop. This secure sense of being held enables the baby to eventually venture out, knowing that mother is near. Mother's holding creates an environment in which the baby can relax and just be. He does not have to worry about survival at each moment, always on edge. In Winnicott's words, he will gain the sense of himself that he can go on being. I want to use that phrase again. To be and to just go on being. Paradoxically, it's something that once you start becoming aware of, you're not going on being. But when you can just go on being in a way that's not self-aware, that is a secure child. That is secure. He can go on being. He not only attends to his own sensations, but he's free to do so. He's also free to look around, to observe the environment. He hears different sounds. He learns some of them are familiar. He notices different people. He can go on to discover his body and discover it's different from his mother's body. When a baby touches his hand, it feels different when mommy touches his hand. His body is separate from mother's body. He's free to do this because he has the intrinsic sense of mother's presence and of being emotionally held by her. Feeling held is what enables the baby, to organize himself, to move up from infant chaos. I believe that one of the most crucial functions that we perform for our patients is that we hold them. We provide a safe and nurturing environment. They are safe enough to just be, although it may take time for their anxiety to abate enough so that they can allow themselves to realize this. Our interpretations are nourishment for their mind. We put experiences and emotional states into words for them. This enables them to reflect and digest their experiences and to discover for themselves what these experiences mean. Once they can arrive at what their experiences mean and that they are consciously aware of the meaning, they are free to go on and develop. Things are organized. It's not an incoherent noise inside, feelings, experiences with no boundaries, with no definition, with no meaning, unformulated. This is such agony for our patients. And the most important part of this is that we stay with them. We do not rage at them. We do not abandon them. We don't disintegrate. We stay and hold them over time, and they get a sense that they too can go on being. Nothing sudden and catastrophic will rupture the connection. This may take time with some of our patients, but that's what we're going for in the beginning. Are there any questions up till now?
Yeah, so couple of points on this last point. And I know this might be premature in the presentation, but just so that I ruined some of the suspense. Does this mean that all we need to do is provide a remothering, or is there something to putting words and understanding to the experience as well that we want to bring to the patient?
That's so I maybe I wasn't clear, but that is really the key, is putting experiences into words. Once, by the way, another book, I don't know if I have it on my list, but I urge everyone to get a hold of Mark Solms and Oliver Trumbull's wonderful, wonderful book called The Brain, The Brain and the Inner World. There's a tremendous amount of neurological research, current neurological research that validates what we have always kind of experientially and instinctively known, that when you put things into words, the language part is what makes the experience for the patient thinkable. I want to point out, by the way, that Freud was a neurologist at first. Why did he become a psychoanalyst? How is it that he came to develop this? Because the neurology of Freud and Charcot in France was not yet up to the task of being able to get to rock bottom and help patients their psyche at the neurological level. It didn't exist. But if you read some of the work of Mark Solms, you'll be absolutely astounded and fascinated as to how far we've come and to how much of what we do has been validated by neurological research.
Okay. Now, would there be room to argue and say that just providing the primitive experience of the holding environment might be enough to eventually heal a patient without words?
I would say that ultimately not, but I would like to that question to share a case experience with you that I had. This was when I was first working, within the first 5 years that I was working. A 12-year-old girl came to me, and I was told she was selectively neutral. I spoke to her parents. She spoke a little at home, never spoke outside the home. I met her, and for 6 months, we were silent. And I was able to sense, I don't know how, this happens at such a basic level, what she was actually experiencing in the room with me, and I put it into words. She said nothing. I met her once a week, and this went on once a week. I held her in her silence where something seemed like something I could formulate, where I felt something I did. And we went on and on. After 6 months, I went and saw her parents. I would work differently with children now. I don't work that long. But in this particular case, this is what happened. And the parents came in and they said, I'm giving the girl a name. She said, Mark is so much better now. What did you do? This is amazing. She silent for 6 months. Now, I was young and foolish, ladies and gentlemen, and I didn't feel I was doing anything. And at a certain point, I terminated the treatment, but I was wrong to do so.
But even then, you were putting words to her. She may not have been putting words to her experience, but you were creating.
That is correct.
So there were words.
There were words, but I did not yet have the professional competence to realize and formulate for myself. You just said, yes.
Okay. Okay. So just want to remind everybody, if you have a question, please hit the reactions tab on the bottom right of the screen and raise your hand. You could question or comment. And one other, and for those of you who could turn on your video, it's always nice to see you. For those who just joined, Chana, one other point is, when you were talking about the borderline personality experience, I just want to comment that, maybe somewhat parenthetically, that when you have a description like that, it objectifies the not objectifies, but it creates more objectivity to the sessions, so that when the borderline becomes enraged with the therapist or becomes anxious and starts acting out, the therapist can now see this as a reaction to something, as opposed to getting caught up in the content of the relationship. That, like, oh no, she's getting angry at me now and I have to defend myself. It becomes more like, okay, there's some anxiety that's taking place in her. Let's try to pay attention to it and wonder what's going on. Almost gives more curiosity.
Okay, that's exactly right. That's exactly what you do. When people are acting out like that, you need to understand that they know they're enraged. What they don't know is that they're experiencing existential anxiety, and they're suffering terribly. I actually only recently learned something very, very interesting. Very interesting technique in dealing with when you have a borderline meltdown, from my esteemed colleague Michelle Cohen, that you're feeling utterly overwhelmed. There's nothing you can do. Anything you try to say is simply going to feed into inflame. We know that, okay? What can you do? You stay there, you hold it, you stay centered. This takes practice and experience with this, okay? You stay centered, and in the moment, you attend to your countertransference. How is this patient making me feel? There's not much else you can do anyway, but this way, by attending to your countertransference, you realize what it is the patient is experiencing and expelling into you. Later on, there will be a time where you will be able, there might be an opening, another session, where you'll be able to metabolize and digest that together with the patient. Excellent. And give it back to her. And but at the moment, what is your countertransference telling you? Okay. Okay. If there are no questions, I'd like to go on. That is the end of what I have to say about the normal autistic phase and those primitive patients that are caught in that. We're now going to go on to Mahler's next phase of development called the normal symbiotic phase, which she placed at 1 to 5 months. And I'd like to modify the LAD because recent infant research has taught us something that around the age of 2 to 3 months, the infant really starts to change. By the time the baby is 2 to 3 months old, we can start recognizing a change in him. We begin to get a glimpse of his personality. Everyone had ever seen the child emerge from this newborn state to that 2-month state where they look at you and smile and react to you. Okay. And the reason that we have a sense of him is because he's starting to individuate. He's gaining a sense of a core self. Again, I refer you to Daniel Stern's work, The Interpersonal Life of the Infant. Okay. What does this mean specifically? What is a core self? He has a sense of himself as a being without being able to verbalize it, but his behavior indicates that he knows he's a self. He can choose to look at something specific. He can stretch out his arm to take a toy. He's also more sociable. He loves to look at faces. He'll smile at you and you'll smile back, and he'll smile back at you. He seeks out mother. We observe that he has a sense of himself as a separate being to some degree. Mahler taught us that in these early months, the baby does not feel completely separate from mother. And after all, his life experience so far has led him to believe that he and mother are two different, maybe two distinct people, but they're one unit, because when he cries, she comes. When he needs something, she's there. This is what we call dual unity. This is the dual part of dual unity. Inevitably, there will be times when mother cannot respond right away. The infant will not get what he needs right away. He'll experience frustration. Melanie pointed out that one of the consequences of this, which is the very normal human circumstance, the mother can't respond immediately. In fact, it wouldn't be good for the baby. The baby has to learn that mother is separate and can't respond to him right away. He learns that mother and he are not one unit. They are, in fact, separate beings, the dual part of dual unity. And that dual part gets reinforced and strengthened. They become two, not one. They have a mutual, but at this point, 2 to 5 months, 1 to 5 months, they have a mutual symbiotic relationship. Now, a symbiotic relationship is defined as two organisms who use each other to mutual advantage. We know how the baby perceives mother. Mother's value him. She's the source of everything he needs. That's his benefit from her. How does mother see the baby as valuable to her? The pleasure that mother feels when she cares for the baby, her nachas, is what she derives from the baby. Now, how is this aspect important to the baby? After all, our focus of study is the baby. And the most important part here is that the baby senses his mother's nachas with him, his mother's love for him. And this sense of being loved by mother is crucial to his development. It becomes his foundation for a positive sense of self. Her love for him enables him to feel loved and lovable. For those of you who are familiar with Heinz Kohut's thinking and with the tenets of self-psychology, this might start to ring a bell for you. The therapeutic equivalent of maternal love, ladies and gentlemen, is empathy. Empathy and attunement are intrinsic to a successful holding environment. Melanie Klein extended Sigmund Freud's work backward chronologically. She discovered that babies have drives, desires, thoughts, and fantasies, just as adults do, as we said. She too formulated her theories of infant development grounded in the basic axiom that the most important aspect of psychological wellness begins with the infant's bond with his mother. Klein taught us that when she gratifies him, she is the good mother. When she frustrates, she's the bad mother. It is from these experiences of gratification and frustration that the concepts of self and other can develop, as we said. The dual experience of feeling good and mother is good, feeling bad and mother is bad for making me feel this way, is the first organizing principle of the mind. Something's either good or bad. Feels good, feels bad. You're good, you're bad. It is the first organizational step up from infant chaos. Very important. Are there questions up to this point? No? Okay. Babies' emotions are always extreme. When babies are not gratified by mother, they feel rage and hate. Yes, hate. Watch one of your primitive patients break down or have a meltdown. Hate. When they are gratified by her, they are in ideal, blissful state. Take note of the primitive splitting employed by infants, and in doing so, consider our more primitive patients who react with rage when they feel we have dropped them and that their needs were not met in the most perfect way. I'm not paying for this session. What are we seeing? Ongoing maternal neglect due to mother's depression or mental illness induced in our patients an ongoing and unrelieved fear that they would not survive, or, as many of my patients have expressed to me in different ways, that they're going to fragment, that they're going to fall into the abyss, that they're going to be blown away, that they will cease to exist. For one moment, let's take note and try to understand, realize how terrifying these states of being are. Being able to formulate it is a major achievement for a patient. This is why these rageful and frantic outbursts feel so overwhelming to us. What is our countertransference response? Well, we're rattled and we're fearful. Why? Because the patient's rage at us is fueled by existential anxiety. He's going to fragment. He's going to die. He's going to melt. He's going to disappear. They will not survive our neglect. We are experiencing infantile murderous rage.
Can you explain what that means?
Sure.
That
When
just that last phrase.
the infant is feeling such that the patient is feeling you've just dropped them, you've ruptured them, you've disorganized them, you have just, okay, you've done this. And they hate you for that, because babies, infants feel very extreme emotions. We know this, by the way, from our observing very young children tantruming. They're gone in rage and anxiety, right? They're gone. Babies are taken over psychologically and physically by their very, very strong and extreme emotions. I urge everyone to please read The Emotional Life of the Infant by Melanie Klein. I've had many people say to me over the years that Melanie Klein feels inaccessible. This is a very accessible paper, and you'll learn a lot. And you'll learn a lot. They'll tell you about our poor patients who are stuck at this developmental state and yet have to function.
What's the developmental necessity for a child or an infant to have such extreme emotions? Is it a survival skill?
Yes, it's not a survival skill. It's the fear. It's the fear that you won't survive. It's the fear you're going to disintegrate. It's the fear you're going to die. Okay. Klein taught us that young infants see each moment as present and now. Now, I see it's getting late. Moshe has his seat strategically positioned so that I can see the clock.
We have till 10:30. We have till 10:30.
Oh, we have till 10:30?
Yes.
Okay, everybody, hold up here because this is really important. Klein taught us that young infants see each moment as present and now. There's this moment, there's that moment, there's the next moment. I am sure all of you have had patients that somehow can't put things together from one moment to the next moment. They are cognitively stuck here, okay? But this is how infants see the world, okay? They don't have a mind to hold past, present, and future. They don't have those concepts. They don't have the experience or the development to have such concepts. In the same way, they cannot see someone as a whole until the second half of the first year. That's when they begin to see mother as a whole person. So how do they experience mother? They experience her in a sense as separate mothers. They do not immediately connect that the feeding mother is the changing diaper mother and the soothing mother. And they know it's the same person, but they can't quite put together the whole person. This is partly because for infants, there's only now. And it takes a lot of lived experience to know that what later or yesterday means, and that infants are not able to formulate for themselves. This is the same lady that fed me this morning. They can't do that yet. Over time, the baby puts together that one person feeds and changes and soothes him. They start putting it together. I mean, the concept of yesterday and tomorrow is going to come much later, but they are able to have a sense that the same person through time changed me, fed me, soothed me. Like all mammalian creatures, the baby has an innate internal recognition of the breast. This was the thing that people find very fanciful about Melanie Klein's thinking. But the fact of the matter is, when sheep are born, they're usually born, by the way, in 2s and 3s. It's very interesting. When sheep are born, they make their way on their knees to the udder. All mammals do. They know how to find their mother's udder. Why shouldn't human infants have an intrinsic knowledge of the breast? They do. And that's where they suck, they find it. You brush their cheek, they know where to turn, and they have an intrinsic knowledge of the breast. In the very beginning, he sees mother in terms of that part of her, the breast. Mother per se is not an object for the infant. Her breast is a part object that he relates to. That's mother. Klein explained that the breast, which is the first part object identified with mother, was both a source of blessing and also a source of frustration when it did not appear did not give sufficient milk. Hence, the beginning of the split in the baby's mind between good and bad is inextricably intertwined with the breast and the mother. The breast that is mother gratifies me, so she's good. The breast that is the mother frustrates me so that she's bad. When the mother can survive the baby's rage at her, that is, he experienced that his tower and rage of frustration do not destroy her. He interjects, takes her in psychologically as strong and able to metabolize his rage and frustration, and she's able to provide security for him. His rage will not destroy her. She can tolerate it, and she loves him anyway. And this enables the baby to feel contained. His rage, which fills him up, is not destroying the world, is not destroying the breast, is not destroying mother. The concept of containment comes from the mother's ability to hold and contain the baby's strong feelings of rage and anxiety and respond to the baby in a soothing and nurturing way. Rage is just a feeling. It is not a destructive force. This is so important for our patients. Not only that we hold them, not only that we stay, but that we survive. And we understand their rage. We put it into words. We can hold it. It is not as terrifying to them as it was. It's just a feeling. Of course, this takes time. The splitting that I mentioned before and the seeing the part of it as the whole is exactly what we experience with borderline and narcissistic patients. They are using us. They are using a part of us. They are utilizing us. Okay, our task is to be a container for their rage, let them use us just as they will, and not feel our own narcissistic wound because they're not seeing us as a person. They're making use of us. That's very important. When you're feeling that narcissistic wound, that the patient is making use of you in some way, it means you're encountering that part of the patient that cannot yet see you as a whole. That's what that's telling you. And that's where the work lies. Likewise, we as therapists are a container for all of our patients' feelings, fantasies, and desires. Over time, they learn that feelings, fantasies, and desires can be put into words. They have meanings, and these meanings can be understood and explored. Okay. I'm going to stop here simply because it's a lot of material. There's more that there's more to do, but I have a feeling it would be better to stop and do it at a different time. This is what I've prepared for tonight. Are there any questions, comments, thoughts?
Yes, please, everybody, open your mouths and your screens, and let's bring them on. Can we talk? Let's talk for a minute about the narcissist.
Okay.
Tell me a little bit. You explained a little bit about the splitting of the borderline,
Right.
and you're describing the using of the narcissist and how the narcissist uses the therapist.
Right.
Can you talk a little bit more about what that looks like, and how do we continue to allow the narcissist to use us while at the same time seeking opportunities to reflect that or create some change there in that relationship?
Okay.
It's two parts.
Actually,
Really.
okay. It would probably be easier for me if I had a specific case example to speak from. But the real important part of this is to allow the patient to use us, not abuse us, but use us. To allow the patient to do that, and perhaps to interpret or put into words and interpret, what it is he feels he needs from us. When we can formulate that for him, he himself will probably take that further and deeper. But I'd like to, I'm not talking about abuse or gaming the system or, I'm not talking necessarily about that. I'm talking about regarding us as using us for his purposes.
Let me give you a case example, and
Please.
Anybody can feel free if you're working with a client that has narcissism. We're talking about a 35-year-old man who I've been seeing for a number of years, and he's actually doing a lot better today than he was a number of years ago. But in his general presentation, and even it still crops up today, but in his general presentation, he experienced any observation that I made of him as criticism. He experienced assumed criticism even before I or his wife might say something to him. And his response to these criticisms, even when it was a request for him to do something differently, or a request for him to speak differently, or a request for him to help or something, his response always was, well, you don't, well, you this, well, you that. In other words, a very, very offensive, accusatory response, rather than ever facing himself and taking some responsibility, even if the content wasn't that he's doing something wrong. So that was the constant just vibe, in the environment, and it would he would go very quickly to rage, if I would make a comment that he didn't like or that he assumed to be critical, and he would actually build it up. So he would start to say, it's not right that you're saying that. And then his voice would start to rise. He'd go on a rampage for maybe 5 or 10 or 12 minutes. And in his mind, he was building up more and more information that was never said about him. And
Right.
until he was yelling and screaming at me. He doesn't do this
Okay.
anymore today, but so what's going on in that process, and how do we eventually have them see something different?
Okay. Well, I think what I'm hearing is that he's he sounds. I don't hear narcissism. I do hear someone with a very shaky ego. I hear someone who um, is uh, constantly feeling on his own without being consciously aware of it. I would say that he's just wrong and doing things wrong all the time. I think that um, he must have. Did he have very critical parents? To one or other of his parents very critical towards him, always finding fault with him?
Straight up abuse. I mean, critical would be an understatement. Straight up abusive,
Critical.
and called him horrible names. Did terrible things. Even
Okay.
to this very day, he showed me certain text messages that they sent him, which were literally unbelievable. In how at 35 and they're in their 60s or whatever, the things that they said to him was shocking.
Okay. So I'm not hearing narcissism. I'm hearing quite the opposite, actually. I'm hearing someone who's never had an opportunity to feel that he's good or worthy or worthwhile. And he sees any request, he interprets that as a deficit on his part that he hasn't fulfilled yet, and you are criticizing him for that. So I think, and kids who were subjected to that never have an opportunity to develop a positive sense of self. It's very similar to what we said, I'll tell you what comes to mind. It's my daughter, but I just I was always so tickled with this. Um, uh, when my grandson was like 2 years old, he got a hold of the cocoa powder, brought it over to the couch, dumped it out around him, and started eating it. And when my daughter saw the mess and he's just covered with cocoa powder and having such a good time, what did she do? She ran and got the camera. That's how she mothers. And her kids all have a very positive sense of themselves. This man never had a chance to do that. A request automatically means that you were telling him he was deficient because he didn't do something. And I think that interventions have to be crafted very carefully, and also an invitation for him to think, an invitation questioning, what do you think about that? This is what I'm
You mean
hearing.
build the self, to build and develop his
To
own.
give him an opportunity to discover that he has one.
Yeah, but besides that behavior, another symptom of his is that he'll make demands of his wife, but never takes any responsibility on his own. He'll agree to do things and forget to do them, always
Mm.
living in his own mind, in his own head. Will promise to come in 5 minutes and not come for 5 hours. doesn't own or take any responsibility and will always yell at the other person for not being, not catering to his needs.
I see. Okay. Um, uh, I'm hearing the part that you're finding to be narcissistic. And I do, I would, to advise here, in terms, we were talking about making use of the therapist. This is, maybe I should make more clear what I mean by that. Uh, but with this particular patient, I don't know what the source of his unreliability really is. Is it because he's internally preoccupied, or we're dealing with a much deeper level of illness than, because when you were telling me this, I was hearing paranoia, and I just wonder just how very ill this this man is. If he's internally preoccupied, he's going to be very defensive. He does not want anyone to discover that about him. And if he's fantasizing or hallucinating, things going on inside of him. And I would just suggest it probably needs further probing. But I'm not hearing narcissism.
Okay.
Yeah.
What would you say the difference is between somebody who's been wounded so deeply because of the degree of chronic abuse that took place and narcissism? Doesn't that produce in other words, isn't the essence of narcissism somebody whose ego is that fragile that they have to prove themselves to be good even if it's at the expense of others being bad? Isn't, what difference would there be if it's coming from a wounded self from that much abuse or from something else? Why don't you call that narcissism?
Well, I don't have DSM in front of me immediately, but I think of narcissism as a personality structure that really has no room for other people at all, and not even as persecutors. He really has no room for other people at all, and he just doesn't. It's a different. It's a different orientation. So it'd be an interesting discussion, but I'm not hearing narcissism. I'm hearing a very fragile ego, and possibly, possibly frank illness. It's something to be explored. But narcissism is different. It's a person who doesn't even realize that other people around have needs, exist. It's like they're not. It's not. Their otherness isn't real to him, except as it serves him. The way you're there to serve me.
Can narcissists recognize that become somewhat attuned to someone else's needs, but only meet them when they're getting their own need met through that? So I love my kids and I'll give them what makes me feel good to give them, but I'm not coming from a parenting model or structure that says this is what's good for the child, this is what's bad for the child, this is what the child needs, this is what it doesn't need. If it makes me feel good to see my child happy in that way, or if it makes me feel good because my child will love me, then I will behave.
Or make me good, make me feel it. I'll do this for the child, because if I do that, it'll make me feel loved by the child. That is a good example of narcissism. Yes, because the child isn't there as a person in his own right. He's there to serve my need to feel like a good father, or my need to feel the glow of love for my
Yes.
children when
So
I
this
give them.
client will do this even when objectively it's to the detriment of the child.
Okay. I hear that. It's an interesting discussion we're having. I hope people are hearing it, but I don't know how to fill in the gap from here to there. There may be narcissism here, and it also might be for him. It might be the narcissistic part of him that has just a desperate need to use the child to feel loved when he himself never did. So I'm, given what you told me about his background, I can see that he would use the child in that particular way as the only way he can feel warmed or by someone else's love, and then feel a little bit more positive about himself. There certainly is a narcissistic component to that, yes.
Okay, let's take a question from Pearl. Go ahead, Pearl.
Okay.
Thanks for,
Hi, Hannah.
thanks for blazing the trail.
Hi, Carol.
A two-part question. I was going to start with the second part, but then I'm like, no, I think this has to come first. And this may come in the second part of your presentation. A client who has either an attachment wound or never had a secure attachment. I'm not sure if those are two separate things, but either way, what would be the best way to bring healing to that client? And then my second part is going to be, and you don't have to remember this part, I'll do it again, that I'm trying to establish a strong bond between myself, the therapeutic alliance, which I'm hoping will heal that wound. I don't know if that's the correct way to go about it. And then something happened with that client, which I'd love for you to interpret, but can you address the first part first?
Okay. Without specifics, I might go off track, so you'll just guide me back if I'm off, okay?
Okay.
All right. Simply being there as a warm, receptive presence is enough for a long time for very wounded people. And they're not going to trust you in that. They're going to test you time and time again in different ways. But if you simply stay steady and faithful and show up and receptive and you listen, I find my style of working is very very receptive and very gentle, very warm and very kind. And now, with that said, I'm interpreting, right? I'm putting what I'm seeing into words for them, but there's always this warmth, this gentleness to it. There's sometimes you can't always just interpret, or you'll have to how do you put it? You just sort of have to say something. Well, I noticed such and such. Is it possible that? What do you think of this thought? To really soften it and to give them room to say yes or no, or I don't think you're right. Even if you are, that 6 months later, they'll discover that for themselves. May even forget that you said it, which is fine. Fine. But I think if you just stay as a steady, warm presence, it'll take time. By the way, this is the first year after almost 3 decades of practicing that I am seeing a couple of people once a week. I generally see people twice a week because that creates a structure. Of course, when you're doing analytic work, it's necessary, but almost always necessary. But I think also seeing people more frequently really helps solidify the connection as well, if that's feasible for you. I sort of answered you in a general way. I'm not sure this was helpful. If you want to, why don't you follow up with another question?
Right. Yeah. So the second question is, thank you. That was really helpful. So I was working with a client who never had a secure attachment, a lot of childhood trauma, complex PTSD. And after working with her for many months, she said to me one day, and here I'm trying to forge a relationship. Okay. She said to me, you're just a voice to me. You're just a voice. And I was like a little taken aback, like, okay, where's that relationship I'm trying to build? How would you address that? What do you think is going on for
Oh,
her?
I believe that she's telling you something very real about herself. I believe she's being very open and honest with you. She's telling you something about herself. She's telling you that she's much too terrified to take you in as a person. She can't. It's much, it's too frightening. And she's letting you know. So once you know that that's what she's doing, that
Mhm.
what she's sharing her anxiety and terror with you, you can start to address it from that point of view, very gently.
Mhm. Mhm. Okay, thank you.
So,
Mhm.
do you mean, by saying that, do you mean that her words, "you're just a voice," limits what peril is to her so that it doesn't have to be too overwhelming? You're
I
just
I
a voice,
th-
she's
I
limiting?
think what she has done is identified her inner experience and told Peril that she did that. She wanted to share that with Peril. That was actually an interpersonal um, communication that she made. Um, Based on what Peril said, this might have actually been a very big step for her to be able to do that. And now Peril knows that she's put into words her genuine feeling that she dare not, herself does not know that she dare not take Peril in as a whole. She dare not. Peril can now work with that.
And if we go to a primitive state, where would we have found, in other words, what is the concept of taking in? Did it, from what I understood, taking in is like the first thing that happens.
Exactly, it is, yes.
So,
But
so
Peril said that she's suffering from complex PTSD. So Peril, tell me if I'm correct about this. What I heard here was that starting at a very early age, in order to keep her mind as intact as she could keep it, she had to keep um, the experience of other at bay. She couldn't allow herself to be connected to. Harold, does that feel correct to you?
I would say that her parents did not establish any kind of emotional bond with her.
Ah,
So therefore, maybe with others, she felt unsafe doing so.
okay. I would say maybe not unsafe. You're adding something very interesting. One of the things that Daniel Stern talks about, I happen to have mentioned it the last time I spoke here, Margie, is the concept of ways of being with. It's a very powerful concept that her parents' ways of being with her were, the connections were remote. And so she never really learned to take in uh, uh, what you and I are doing right now. We're taking each other in. I mean, the screen, it's one screen to another screen. You and I both know that it's not a cup of coffee, but 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 we're taking each other in. She may never have developed the capacity to do that. And that's something that you can over time build. She's sharing this with you. And that I think is very significant, as I said. She's
Yeah.
putting it towards her real experience because she wants you to know.
Yes, she also said that she can't look me in the eye. She said, I don't know if you noticed, but I can't look you in the eye. I'm too ashamed.
Too ashamed. Explore shame. One of the things, by the way, that we really overlook as therapists is the feeling of shame. There's a great deal of shame around feeling deficient, around there's a lot. When a patient tells you that they feel ashamed, it's really something that it's a big thing they're telling us, and the question is to explore it. What is the shame about? give them an opportunity to put that into words. It would be very instructive, I think, for both of you to find out what she's ashamed of.
Yeah, didn't seem to be able to identify it. I think it has to be very slow work with her.
For sure, definitely. But asking the question, you might come back to it a few months later,
Right.
asking the question has already created it in the field between you. And she knows you care about it.
Thank you so much.
It doesn't seem uncommon or unfathomable from what I've seen that people feel just this pervasive sense of shame without necessarily being able to pin it down to a particular incident. And I imagine that this is something that's very experiential. Growing up where they feel inadequate or ignored or neglected, or maybe more of a subtle criticism where they can't necessarily pin it to a particular person, place, time,
That's correct.
or thing. But there's just this like, I shouldn't have been here. There's no need for me. There's no reason for me. I'm just in the way. And
that's that. I'm not sure that what you're expressing now is shame necessarily, but it is feeling very small, and just putting that into words for someone. It seems to me that you feel very small. Might get them associating in a way that would be very productive.
would you recommend using the word small to them
Yes,
with it, even if they don't
definitely.
use it?
Yes, certainly. In fact, what you're describing at the moment, I think using the word would be very helpful to them. It would help them formulate for themselves what it is they're really experiencing. Yes, I think so.
Okay. So how would you consider shame and small different? What would you
Well,
describe as shame?
shame, it would be more, I wouldn't want anybody to know that I can't do this, or I wouldn't want anybody to know that I did do that. I think that is what I would call shame. Shame is closer to embarrassment, but it's a private thing to yourself. You wouldn't want anyone to know that you have this deficit. You wouldn't want anyone to know that you don't know this or do know that, or whatever. It's a feeling. It's different, I think, from feeling small, insignificant, not of any value to someone, or to some, not of any value. I think it's different.
Okay. Let's take a question from Dr. Kaplan. Elliot Kaplan, go ahead.
So from your response to peril, I'm hearing a lot of empathy and warmth toward her client. And I guess my question is, as I normally ask on Moshe's sessions, what's the percent of empathy, warmth, and genuineness that you do in your psychoanalytic work, and how much would you say that and what percentage would be interpretation of what the client is offering? How would you break that down?
Mm-hmm. I think it's a very good question. Interpretations are sometimes viewed as these cold, intellectual, incisive comments. They're not. There's really an art to interpreting in a way that your language and what you can, first of all, that the language is everyday language, but it's actually addressing the unconscious mind. That's something that you with good supervisors, you learn to do. And always, in terms of the empathy, you're always dealing with a person who's in a great deal of pain. And by making something explicit to someone, you are certainly helping them, but you also are enabling them to more sharply recognize something that's very painful to them. And that's the reason that when we interpret or we put things into words, we're always mindful that, number one, this is what the patient wants from us, and number two, it's going to bring with it pain and sadness. So keeping that in mind is going to make us very empathic when we interpret.
So when you're sitting with a client, would you say that you're 80% empathic and 20% looking for the pattern, the interpretation?
I don't see them as split, Elliot. I'm always listening to what things mean on the unconscious level. And when I feel the moment is right, but the patient can hear it, I put it into words in a way that's as gentle as possible.
So Elliot, I think, is that the first time you've ever got a 100% warm and empathy? The answer is 100% warmth and empathy. And even in the context of the interpretation, using warmth and empathy to convey that.
Yeah, well, my impression of psychoanalytic work is that it really is based on the warmth and empathy, and it would seem to me that would be the primary piece, and that the interpretation is not necessarily the primary piece, but it's certainly part of the process of working with that patient.
So in other words, if the analyst were actually misinterpreting but conveying acute warmth and empathy, they may cause the same healing.
In my view, sorry.
Okay, I trying to remember exactly what happened. It was very interesting. I have a very, very narcissistic and primitive patient. When I told him that I was leaving for a week, he said to me, "You can't go, I need you." And it was the first time he was ever able to say something like that. So I don't usually step out, but I said, I find that very touching. And he said to me, "You've got it all wrong. I'm not going to miss you. I need you." And I realized that this is object usage. This is where he's at. I was thinking he was at a more developed place, that he was going to miss me. He was going to have, feelings that I'm not here. No, it wasn't. His object isn't there for him, and he's you can't leave now. It wasn't touching. It was narcissistic. So it's like, just thought I'd throw that out there. And he was honest enough to tell me.
Which itself was worthy of interpretation.
Excuse me?
Which itself was worthy of interpretation and some level of acknowledgement of progress.
Yes, in this case, it was his honesty and being able to just come back at me and tell me what he was really feeling and thinking happened to have been a good thing. Yeah. Anyway.
And was he not struggling with this acknowledgement that like he didn't feel that there was something, so to say, wrong with needing you and demanding that you must be?
Not at all.
So that's a classic example of someone who doesn't have room for another person.
That's correct.
Outside himself.
That's right. That is real object, but the fact is that object usage and the fact that I could chuckle in response and acknowledge that this was true and go on to the next was actually a good thing. I wasn't wounded by the fact that he's making use of me. I metabolize it, accept it, and over time, hopefully, he would come to see me as an other with human insides, just as he has them. We're not there yet.
So the question really is, how do you move beyond that? I know that there are different approaches in working with narcissists, but in your conceptualization, how do you help the client get beyond that if you just allow it to fester and perpetuate?
Well, I think that Peter Fonagy's wonderful theoretical, the whole idea of mentalizing, eventually, there'll be an opening for helping people to try to put themselves in someone else's shoes and imagine how they would feel. There does become room for that over time.
And time means the evolution or development of a secure attachment. Is that what time means?
It definitely starts with the evolution of a secure attachment, but it also, it's hard to get specific. If a person finds that he's narcissistically, that he's not successful in his relationships, then one of the things you can really do is appeal to people on the level of their narcissism. This isn't working for you. Why don't we try something else?
What you say, this isn't working for you? What?
This isn't
What's-
working for you. You can't hold on to a relationship with someone. This isn't working for you, what you're doing. Well, maybe thinking about how she feels when you say something like that. Tell me, how would you feel if someone said that to you? Let's say you were struggling with something, whatever the situation was, and someone made fun of you just as you would. How would you feel? Now, there becomes room to start building this. I don't want to get too explicit because it's not a concrete thing.
Right.
But eventually there may become room in the relationship with a person who's like at that narcissistic level for him, just in his own self-interest, that this isn't working. What he's doing with people isn't working for him. It's not working for him. He's failing. That's enough of that's a good entree. Your narcissistic self-interest. Let's try looking at it another way. Let's try developing your human empathy. That might be more successful for you.
But I imagine that the place that has to begin is only once the client feels safe enough with a therapist to be able to explore. And there needs to be some level of attachment.
Certainly.
Yeah.
Certainly. Mhm.
What would happen if you there's someone like Fritz Perls would, I imagine, would attack the client on in an initial session and have him face himself. Can that be done artistically, from the get-go, or must it be only once the attachment is secure enough? Or can that be the basis for a secure attachment?
Well, I don't look at secure attachment in and of itself as a thing. It's sort of like it's a concept, but I think one of the things I was trying to bring out is that there are so many components, so much that a child has to successfully, a child that a parent has to successfully bring a child to, for this attachment to be what we will now call a secure attachment. It's a descriptive term in my view, not necessarily a theoretical term. I hope people don't take offense at that, but I think that the holding environment, the putting things into words for people, the allowing them to digest what you've said, and you're digesting what they're saying, and giving it back to them in metabolized and benevolent and caring way. All of this is being interjected by the patient, and over time, the hope is that that is, his connection to you, and his learning how to put things into words, and his learning how you relate to him and you receive him, will be something that he can interject and take to other relationships. That's really what I'm talking about. When he feels comfortable doing that, comfortable with himself, comfortable taking these new ways of being in his relationships with other people, when that solidifies and builds, then then I would say he can then learn to feel securely attached, because this works. So I think that kind of like the term secure attachment really has so many different components that make it possible.
Okay. Chana, I want to thank you for this wonderful, profound presentation. I know that a lot of thought and work went into it. It's written beautifully. It should probably be published, and put all these papers together, and you can write a book. But it really gave a lot of context and understanding as to how early childhood develops. And now I'm assuming the next time we meet, it's going to you're going to take that into adulthood and start to describe how
Well,
adults.
what I was next going to do is take it into the next phase of development, which has several sub-phases, and we would culminate with at age 3, which actually, if a child is securely attached by age 3, 4, 5, let's assume there's no rupture, he's really at a very good place. So I know that might sound a little surprising, but on the assumption that the parent-child relationship goes on being that took him up to the point of object constancy, that it will take him beyond that, and that was where I was going to stop. It's going to take a full session,
Okay.
a full.
Okay. Well, thank you again for tonight, and we hope to see you again in a bit.
Okay.